Meanwhile, Sheena Mani is a consultant vitreoretinal surgeon at Dr. Tony Fernandez Eye Hospital in Alua. And as we have seen here today, she was the person who was instrumental in bringing together the Smart India study to be discussed in our conference. And congratulations, Sheena, for that, and we are looking forward to your talk.
So my topic is artificial intelligence. That's the new buzzword everywhere, not only in diabetic retinopathy. So there were two articles published under the umbrella of the Smart India study. So I'll just go through that. A disclaimer, because there's a lot of research and there's a lot of work, and I've really not gone into everything. So these are the only two papers that I will be talking about. So we know that existing screening methods are, today how we screen for DR and STDR are either by a trained ophthalmologist or a desktop-based mydriatic retinal imaging, and then we grade the DR severity and then treat accordingly. However, both these methods are very resource intensive, and in our country where the numbers are huge, there are many challenges. We have a large number of sight-threatening DR alone, forget about DR. And with compared to the numbers of STDR, the personnel that are trained for detecting these are fewer. The infrastructure is not very adequate, and it's not uniformly distributed throughout the country. And even risk factor models, like Dr. Thomas had discussed earlier, is not ideal when compared to an actual DR fundus imaging. So how do we go about this, and what's the way forward? We would like to have low-cost portable cameras which could be used in a community setting. That would be the best way. And if the entire process of detection and screening could be automated, that would be very good given the population and the numbers that we have. So low-cost portable cameras, they are usually non-mydriatic, and they are handheld with no stabilizing platform. So they can be challenging to get good images. Even if you go with a camera, the images may not be very perfect, or it may not be good enough to even grade what stage of retinopathy the patient has. And invariably, the patient may have, these are little elderly, they have comorbidities like a small pupil and a cataract. We faced that challenge during the Smart India. We were not getting good images to even grade. And as the literature suggests that gradable images in a non-mydriatic camera is only 70 to 75% versus a dilated image. So increasing the gradable images is imperative to detect STDR. So coming to the second method of automating DR screening, again, the first step is to get gradable images. Only once you get good images, then only you can grade it. So that is usually the work work done by the person on the field. They will have to assess whether the image is gradable or good enough to even be uploaded to a reading center. And then only the next step comes is the actual grading, but before that we need the gradable images. And then of course the final step is actually detecting STDR, which is done by the ophthalmologist. So the two papers under the Smart India umbrella was, the first paper discusses about how a deep learning model was developed to be incorporated in the non-mydriatic portable camera. So it's basically a device which helped the field worker get good images. The field worker is not a trained ophthalmologist. They are just trained to go in and get images. So they should know, is this image good enough to be uploaded or not? That is what the AI and the deep learning model was taught to do. And the second paper was, again, the deep learning model could identify sight-threatening DR from these images. So these are the two papers. Both were published in scientific reports, one in 21 and the other second in 23. So the rationale was, deep learning model can, at acquisition, that is incorporated in the camera, can increase STDR detection rates, and whether these models can classify the gradability. It's not whether these models can grade the images, whether they can just classify whether these images are gradable or not. There's a subtle difference between the two. So this was between August 2018 and 19. December 2019. There were 20 sites involved, and the images obtained were by field workers. They were trained over 1 or 2 days. That's all the training that they had, and to capture these images. And there were 2 images taken from each eye. One was disc center and the other was the macular center, and there was no limit on the number of images because basically we wanted to increase the gradability of the images. And then it was classified as whether these images were gradable or not. So the deep learning model, how was a sample was created from these images, and then that was given to train the model. And then this model, that is the model was compared to an ophthalmologist, how it was compared, how good the gradability of the images were, and the small model was also compared to a large model, that is a desktop-based camera. So these are the 3 things that were assessed in this paper. So what was the definition of gradability? At least less than 50% of the image is obscure, that is more than 50% should be seen, and more than 50% should be clear, and the entire optic disc should have been captured. So that is what is termed as a gradable image. So when they compared, this is the compact model is the one that goes into the portable camera, and the large model is one that is on the desktop camera. So when they compared both the models, both were reasonably all right, with the area under the curve of 0.96 and 0.97. Only the smaller model took a little more time in assessing whether the images were gradable or not. Again, both these models were compared to one grader, the grader 1, who was a trained ophthalmologist, and that again was fairly all right. And again, there were 2 graders involved. The intergrader agreement was also acceptable. So what this concluded was, one can incorporate compact deep learning models to classify whether these images are gradable or not. So that is the first step that we have in the whole automation process. The second paper, the aim was again to develop a system to actually grade or point out referable DR. So which of these patients need to go to the hospital, which of these eyes need further treatment. So that is to identify referable DR, and then again to compare the accuracy of this to risk-based models. So what do you mean by risk model is, you identify all the risk factors, you know that all these risk factors are there, and so such and such patient is highly likely to have VTDR, versus just a fundus screening, and is that, which is better, are both equal, is what was the aim of the study. So again, the same process. There were 2 images that were uploaded onto cloud server and graded, again by the primary, secondary. If they differed, it was by the arbitrator. And then divided into 2 categories, referable or non-referable. Referable was either moderate to severe NPDR or PDR, or referable DME. So, and then the model was developed. It was by a deep learning method where the model was fed all the images and they were able to identify what was referable. So this was the entire process in a picture form. And so then it was the ability to predict referable DR and DME from these handheld cameras were assessed, and it was fairly good. The ideal way would be with both the fields, but even with single field inputs, the area under the curve was fairly good. And when assessing risk factors of individuals, like duration of DME, when all the risk factors were assessed, the duration of the diabetes was the most predictable to point to whether a person may have STDR or not. I'm not going into this. So this again is the same thing. Both the fields, if you have a disc-centered and a macular-centered field, would be the ideal way. But any of these frames could capture reasonably well presence of STDR. And if you assess all the risk factors, again, duration of diabetes is the most predictive for STDR. And to conclude, both these papers together, compact DL models can effectively classify non-mydriatic handheld retinal image gradability in the community setting, so that each word is important. It's not, a trained person is not going into the community and getting the images done. And also, we developed a deep learning system that detected referable DR from retinal images using, again, handheld non-mydriatic fundus camera by non-technical field workers. And the image-based outperformed all the risk factor-based models. So at the end of the day, ideally, a retinal image would be the best way to identify STDR. However, even risk factor-based models also work, but not to that extent. And thank you.